Good afternoon. I'd really like to thank all of the organizers for the privilege of joining you on this glorious day in this beautiful setting to discuss some of our work related to inherited vasculopathies. In keeping with the theme of this meeting, the focus of my talk is going to be on the work that we do downstream of finding disease genes and disease variants to really try to understand the pathogenic sequence for a given disease process with the hope of deriving new therapeutic strategies in that manner. As many of you know, my work has focused for many years, in fact decades, on a connective tissue disorder known as Marfan syndrome. As most of you know, Marfan syndrome is a systemic disorder of connective tissue with dominant inheritance and a prevalence of about 1 in 5,000. Syndrome is highly variable, but shows cardinal features in the ocular, skeletal, and cardiovascular systems, including dislocation of the ocular lens, overgrowth of the long bones, but most importantly, progressive dilatation of the root of the aorta at the level of the sinuses of Valsalva, that will lead to aortic tear, rupture, and early death if left untreated. In 1991, we utilized a rather conventional positional candidate approach to show that mutations causing Marfan syndrome occur in the gene that encode the connective tissue protein fibrillin-1. So what do we know about fibrillin-1? We knew that monomers aggregate to form complex extracellular structures called microfibrils. And that microfibrils cluster around the maturing ends of an elastic fiber during embryonic growth. This simple spatial and temporal relationship led to a firm belief that you need a lattice of microfibrils to make an elastic fiber during embryonic life. And if you think about it, this really boded poorly for the development of treatments. It suggested that children with Marfan syndrome are born with inadequate elastic fibers, and that they therefore have an obligate structural predisposition for their tissues to fail later in life, that there's nothing that you could do after birth. So I can remember the day and even the moment, walking into a patient room, seeing fingers just like these and thinking this just doesn't make sense. Why would weakness of the tissues cause the bones to overgrow? For that matter, why would weakness of the tissues cause the craniofacial features of Marfan syndrome, or the low muscle mass and low fat stores that are so characteristic of the condition? Each of these findings was more suggestive of altered cellular performance. So to summarize about 10 years of work in one slide, we were able to show that microfibrils composed of fibrillin-1 serve a second important regulatory function in that they bind the large latent or inactive complex of the cytokine TGFβ and suppress TGFβ release or activation. We were also able to show that in the microfibrillar deficiency state, as in Marfan syndrome, there's inadequate matrix sequestration of latent TGFβ, and on that basis, promiscuous activation of the cytokine that can then go on to interact with its cell surface receptor and set in motion an intracellular signaling cascade that includes phosphorylation of SMAD2 or SMAD3 that then partner with SMAD4, translocate to the nucleus, and mediate transcriptional responses. Perhaps most importantly, we show that this high TGFβ signaling state in Marfan syndrome has phenotypic consequences, including developmental emphysema, aneurysm progression, thickening and dysfunction of the mitral valve, and skeletal muscle myopathy, because each of these findings could be greatly attenuated or even prevented by treatment of Marfan mice with a pan-specific TGFβ neutralizing antibody. Now, around that time, we asked, is there a drug, and even better, an FDA-approved drug, that might mimic this protective effect? And our attention turned to angiotensin receptor blockers, and specifically a drug called losartan, that had been shown to lower blood pressure, something that we thought was good for people with aneurysm, but also to attenuate TGFβ signaling in rodent models of chronic kidney disease. So how does losartan work? Well, it's known that angiotensin II signaling through its type 1 receptor can increase production of TGFβ ligands, TGFβ receptor subunits, and also important activators of TGF-beta such as thrombospondin-1. In contrast, angiotensin II signaling through its type 2 receptor is thought to antagonize many of these AT1-mediated events. So in this view, AT1 is the culprit pathway, whereas AT2 signaling is potentially protective. We reason that selective blockade of the AT1 receptor might actually shunt signaling through the protective AT2 cascade, in that manner achieving very potent therapeutic effects. So we went on to do a trial of losartan in mice with Marfan syndrome. Here we compared the performance of losartan to that of the adrenergic receptor blocker propranolol that lowers blood pressure but does not address TGF-beta. We found that propranolol treatment did lead to a relative but significant reduction in aortic root growth rate, but this did not result in any improvement in aortic wall architecture. We still saw thickening of the aortic wall, a high collagen content, and disarray of elastic fibers. And there was clear evidence for residual high TGF-beta signaling, as shown by nuclear accumulation of phosphorylated SMAD2. In contrast, no observer could distinguish losartan-treated Marfan mice from their wild-type counterparts by any histologic or functional parameter, including complete normalization of aortic root growth, complete preservation of normal aortic wall architecture, and really exceptional attenuation of TGF-beta signaling, as shown by immunohistochemistry, but also by quantitative Western blot analysis. So around this time, we felt compelled to treat a subset of children with the most severe presentation of Marfan syndrome. These children show unrelenting growth of their aortic root despite maximal treatment with beta blockers and/or ACE inhibitors, reaching surgical endpoints or death during early childhood. These are the aortic root growth curves for the first two such children that we treated with losartan, showing a striking plateau of aortic root growth coincident with starting the medication. In total, we treated about 20 such children, and on average saw a 10-fold reduction in aortic root growth rate compared to their performance on prior medical regimens. So since that time, there have now been a number of clinical trials of losartan in Marfan syndrome. A trial in Taiwan used the identical design that I just described for you. They saw about a 9-fold reduction in aortic root growth rate in severely affected children. Another trial showed a very significant reduction in the rate of aortic root growth standardized to body size. And finally, a different trial in adults with Marfan syndrome saw a significant reduction in aortic root growth rate upon adding losartan to the medical regimen. Now, as many of you know, a very large trial in the United States had somewhat interesting and different results. In this trial of children and young adults with Marfan syndrome, what was observed is a very low rate of growth of the aorta in both the beta blocker or losartan treatment groups with a significant decline in aortic root Z-score over time, but there was no significant difference between the arms of the study. Now, what's important to note for this trial is that it utilized a very high dose of beta blocker, a dose that's not typically used in clinical practice, up to 4 milligrams per kilo per day, whereas a more conventional dose of losartan was utilized with a maximum of 1.4 milligrams per kilo per day. You'll notice that the rates of aortic root growth in both treatment groups is far less than that previously documented for untreated pediatric patients, and also for patients treated with typical attenuates dosing. And we've now gone on to look at the effective dose in our mouse model of Marfan syndrome and see that with beta blockers, even at quite a substantial dosing or even ultra-high dosing, you see a very slight, again, a relative reduction in aortic root growth rate that kind of maxes out as the blood pressure lowering effect is plateauing. In contrast, with losartan, at every dose that we've used, we see further improvement in aortic root growth rate, and at the highest dose with significant, mild but significant regression in aortic root size over time. So I think the general sense is that we've made some progress, but there is still substantial room for improvement. Now, up until this point, my comments have focused on so-called SMAD-dependent or canonical TGF-beta signaling. But it's also known that ligand-activated TGF-beta receptors can support so-called non-canonical signaling cascades, prominently including the myogen-activated protein kinases ERK, JUNK, and P38. When we asked whether any of these non-canonical cascades might be contributing to aortic disease, we found truly shocking levels of ERK activation in the ascending aorta of Marfan mice compared to their wild-type littermates. Now, to decide whether ERK was simply a marker of disease or rather a driver of disease, we gained access to an orally bioavailable, potent, and highly selective MEK antagonist called RDEA-119, and showed that this was every bit as good as losartan in suppressing abnormal aortic growth. We were able to document that indeed this agent had potent effects at suppressing ERK activation without any effect on any of the other signaling cascades under consideration. So we thought we have a new landmark. ERK is bad, and we wondered how we could leverage this knowledge to address understudied, vulnerable, or underserved patient populations. Now, one such group are women with Marfan syndrome who choose to become pregnant. They truly show an alarming rate of aortic rupture and death in association with pregnancy that historically has been attributed to increased hemodynamic stress. But it seemed odd that the vast majority of dissections are occurring within the weeks after delivery, and that this risk was not altered by C-section or the use of antihypertensive agents. So we asked ourselves, what initiates toward the end of pregnancy, is maintained after delivery, and might synergize with some of these signaling events that we had defined for aneurysm and dissection? And the hypothesis that we came up with involved the hormone oxytocin, which is needed to initiate uterine contraction and milk letdown. Its release peaks at the end of pregnancy and is sustained during breastfeeding, and its receptor is upregulated in the aorta in response to estrogen or pregnancy. We became really excited when we learned that the mechanism by which oxytocin stimulates peripheral tissues is through ERK activation. So to test this hypothesis, we needed a good model of pregnancy-induced vascular disease. Unfortunately, a very severe recessive mouse model of Marfan syndrome established by our colleague Keiko Ramirez shows essentially 100% death due to aortic dissection within the first 3 weeks after delivery. This is strikingly different from non-pregnant females shown in purple or male Marfan mice shown in blue. So initially we asked a very simple question. What would happen if we allowed these mice to become pregnant, allowed them to deliver, but simply took the pups away right after birth to prevent lactation-induced oxytocin release? And the answer was that this simple manipulation transitioned survival from near 0% up to 70%, simply by removing the pups. We next asked what would happen if we used a potent, again, very selective oxytocin receptor blocking agent. And this again transitioned survival from close to 0% up to around 100%. Now we found that the outcome in these mice correlated perfectly with the level of ERK activation in the aortic wall, which is elevated in Marfan syndrome, greatly exaggerated in Marfan mice that are allowed to become pregnant and to lactate, reduced back down to baseline levels by removing the pups, and also by use of the oxytocin receptor antagonist. Now again, to decide whether ERK is truly the driver of disease, we made use of a newly FDA-approved ERK inhibitor that's marketed by GlaxoSmithKline for use in cancer, and found that this also led to a remarkable suppression of pregnancy-associated aortic dissection. So we really think that this is a foundation finding and something that could transition to better medical care for women with Marfan syndrome. Now, all news isn't good news. We decided to ask whether all antihypertensive agents are protective in Marfan syndrome, and specifically calcium channel blockers, which are currently considered second-line antihypertensive agents in this disorder. We were initially very optimistic. If you looked at the literature, you could find reports that some calcium channel blockers, such as amlodipine, could reverse ERK activation in hypertensive rats, that other calcium channel blockers could reduce ERK activation in synergy with angiotensin receptor blockers in arterial injury models. So we had high hopes going in. We used amlodipine and followed these mice by echocardiography. So here is the heart aortic arch of a wild-type mouse. This is the normal appearance of the aorta. In our Marfan mouse that had not received any additional treatment, you can see the flare of the proximal aorta just as it's leaving the heart. In normal mice given amlodipine, you don't see much. Perhaps the ascending aorta is looking slightly generous. But in virtually 100% of Marfan mice given calcium channel blockers, we see the hyperacute emergence of giant ascending aortic aneurysms. In fact, tripling of the aortic size within about 3 weeks of starting the medication, with death due to aortic dissection within 5 weeks. Shown quantitatively, there is acceleration of aortic root growth with calcium channel blockers in Marfan syndrome, but a much greater accentuation of growth in the more distal ascending aorta, an aortic segment that's traditionally spared in Marfan syndrome. We asked, is this just a feature based upon this very high dose of calcium channel blockers that are being used? But we found the identical effect even after ratcheting down the dose about 5-fold. Here is the synthetic lethality seen in these mice in response to calcium channel blocker use. Now, we asked, is this unique to amlodipine, or perhaps is this a class effect? And found that virtually all calcium channel blockers that were tested showed accentuation of both aortic root and more distal ascending aortic growth. Now, contrary to the initial prediction that we had made by review of the literature, we found that calcium channel blocker use in Marfan mice associates with accentuation of both canonical SMAD-dependent TGF-beta signaling and also non-canonical cascades, prominently including ERK. Now, again, we wanted to know whether ERK is the culprit in this context, and to determine this, we treated mice either with calcium channel blockers alone or with calcium channel blockers in combination with the MEK inhibitor RDEA119. And we found that blocking ERK activation essentially eliminated this deleterious gene by environment interaction, including prevention of early death due to aortic dissection, in clear association with suppression of the abnormal ERK activation that had been induced by calcium channel blockers. Now, to show you the magnitude of this effect, here again is an ascending aorta in an amlodipine-treated Marfan mouse. You can see that there's a huge ascending aneurysm, a tremendous fibroproliferative response within the aortic wall with dramatic fragmentation of elastic fibers. In mice that received calcium channel blockers plus ERK inhibitor, we not only remove the effects of calcium channel blockers, but bring the aortic wall all the way back to normal, suggesting that ERK is really the dominant player in this disease state. Now, we had a problem. You know, again, if you went to the literature, you could find tenuous associations between angiotensin II signaling, TGF-beta activity, and ERK activation, but the question was, where do calcium channel blockers fit into this scheme? If we looked more closely at the literature, we found that both TGF-beta and AT1 signaling have the ability to activate phospholipase C that then through an IP3 PKC axis culminate in ERK activation. So in keeping with this hypothesis, we saw that calcium channel blocker treated Marfan mice indeed showed excessive PLC and also PKC activation. We reasoned that if this mechanistic hypothesis were correct, then there should be a beneficial effect of selective PKC antagonists such as enzastaurin. And indeed, we found that treatment with both calcium channel blockers and enzastaurin led to a significant reduction in ascending aortic growth compared to mice that had received calcium channel blockers alone. So at this point, we wondered, have we only learned something about this very artificial context, Marfan mice given high doses of calcium channel blockers? Or perhaps have we learned something fundamental about the disease process itself? So to address this, we asked whether enzastaurin has the ability to attenuate aortic growth in Marfan mice that had not received calcium channel blockers. And we found that this effect was quite substantial. In fact, the greatest therapeutic effect of any intervention that we had seen thus far in Marfan mice, with regression in aortic root growth over time in association with clear attenuation of both PKC and ERK activation. So again, if this axis were correct, we reason that the FDA-approved drug Hydralazine should have a therapeutic effect because it acts at least in part through suppression of IP3-mediated PKC activation. Once again, we saw this dramatic protective effect of when we used hydralazine in Marfan mice in association with the expected signaling effects, including attenuation of both PKC and ERK activation. And we were really excited about hydralazine because unlike other antihypertensive agents such as angiotensin receptor blockers, hydralazine is safe to use during pregnancy. It could be used in pregnant women today. So we went now back to our pregnancy model and found that treatment with hydralazine led to a very significant protection from both aortic growth and pregnancy-associated aortic dissection, and that this protective effect was far out of proportion to propranolol, the beta-adrenergic receptor blocker that simply lowers blood pressure but does not address these signaling events. So we think that this, again, could translate very quickly to medical management of pregnancy-associated risk in Marfan syndrome and perhaps other connective tissue disorders. So all in all, we do have a new mechanistic axis for vascular disease in Marfan syndrome. We've poked and prodded this pathway in every way that we could imagine and found that all three manipulations that were predicted to worsen aneurysm indeed did worsen aneurysm, whereas all 6 provocations expected to attenuate or prevent aneurysms had a substantial protective effect. You might ask, this is all fine and good. We've learned a lot about mice. Does this have any relevance to people with Marfan syndrome? So we're just beginning to try to address this issue, but we've partnered with a large registry called the GenTAC registry that's collecting clinical information on large numbers of patients with aortic aneurysm, including many patients with Marfan syndrome. And we asked if at the time of registration in the registry, someone was coded as taking a calcium channel blocker, did they have a higher risk of aortic dissection during the follow-up period as compared to individuals that were not taking calcium channel blockers? And we found that the odds ratio among people taking calcium channel blockers for aortic dissection was 12.5. And that also there was a higher risk of aortic dissection in other presentations of thoracic aortic aneurysm if calcium channel blockers were being used. Now we reason that if the clinicians were paying attention, they would have noticed more rapid growth of the aorta and would have performed surgery during the follow-up period. And we found that the odds ratio for surgery among people taking calcium channel blockers was about 5.5. That's with Marfan syndrome. And again, this appeared relevant to other etiologies of aortic aneurysm. So in the year about 2005 or so, my dear friend and colleague Bart Loeys and I recognized and described a new aortic aneurysm syndrome that had many features in common with Marfan syndrome, a light curvature of the spine, chest wall deformity, long fingers, and aortic root aneurysm, but also many unique features such as hypertelorism, cleft palate or bifid uvula, craniosynostosis, club foot deformity, and certain forms of congenital heart disease. Most importantly, these patients show a very diffuse arteriopathy with widespread arterial tortuosity, and also aneurysms not just at the aortic root, but at many sites throughout the circulation. Perhaps most importantly, these aneurysms tended to tear or rupture at young ages and small dimensions when compared to Marfan syndrome. We've had the privilege of caring for over 300 families with this condition that's referred to as Loeys-Dietz syndrome. Now, based upon what we had learned about Marfan syndrome, we reasoned that this condition might also relate to altered TGF-beta signaling. And in fact, we were able to show that the vast majority of patients with this condition have heterozygous missense mutations in the genes encoding either subunit of the TGF-beta receptor. Now, these mutations are all clustering in the kinase domain of their respective receptor subunit and are predicted to lead to loss of function. Yet by mechanisms that are not fully understood, when we look at the tissues in patients with Loeys-Dietz syndrome, we see the clear signature for high, paradoxically high TGF-beta signaling, here shown by nuclear accumulation of phosphorylated SMAD2. So Elena Gallo in the lab went on to make and characterize mouse models of Loeys-Dietz syndrome and showed that they also show this clear signal for paradoxically enhanced TGF-beta signaling in the aortic root. Elena was able to show that losartan was just as protective in Loeys-Dietz syndrome mice as it was in Marfan mice, showing complete prevention of abnormal aortic growth in association with a complete abrogation of TGF-beta signaling within the aortic root, which again you can see is very elevated in Loeys-Dietz syndrome mice that did or did not receive propranolol. So the agent that did not have a protective effect is associated with residual high TGF-beta signaling. The one that showed complete protection completely abrogated TGF-beta signaling. Now, there are now many so-called TGF-beta vasculopathies, and indeed the Loeys-Dietz syndrome phenotype is now seen in association with heterozygous mutations in genes encoding many primary effectors of TGF-beta signaling. Now, while all of these conditions associate with a tissue signature for high TGF-beta signaling, as I mentioned, at least some show a primary genetic defect that would intuitively lead to low TGF-beta signaling. And this has really engendered controversy in the field regarding the precise role of TGF-beta and also the therapeutic potential of TGF-beta antagonism. So in considering paths forward, we decided to characterize genetic modifiers of vascular disease in Marfan and Loeys-Dietz syndrome. In essence, we were asking, how does nature modify Marfan syndrome in this particular study? So over the course of many years, in collaboration with Bart Loeys, Julie DeBacher, and Anne DePape, we had identified 5 truly exceptional families with Marfan syndrome that showed discrete intrafamilial variation in vascular disease. And by that I mean half the mutation carriers had huge aneurysms or dissections by the time they were 15 or 20, and the other half of mutation carriers in the same family showed no aneurysms now in their 40s, 50s, and even 60s. So we used positional linkage methods to try to identify modifier loci, And quite remarkably, all families tested showed protective variation on the long arm of human chromosome 6 with a significant LOD score. Now, there are 32 genes in the critical interval, but one caught our eye immediately, MAP3K4, which is a mitogen-activated protein kinase that activates molecules such as ERK and P38. So we didn't have the ability to recruit additional exceptional families, so we returned to our mouse model of Marfan syndrome and found that when we introduced simple haploinsufficiency for MAP3K4, we could completely normalize the rate of aortic growth, and that this occurred in association with full normalization of both ERK and P38 activation within the aorta. So this fit in very nicely with our mechanistic cascade, showing that variation at this level has the ability to be protective. And we also turned to our mouse models to see if we could identify additional modifier genes and variants. And we relied upon an observation in the literature that the C57 black 6 background, as opposed to SV129, exacerbates TGF-beta deficiency phenotypes and ameliorates diseases driven by TGF-beta. So the conclusion from the literature is that the black 6 background imposes a relative TGF-beta deficiency state. And this seemed to be the ideal opportunity to ask whether it's low or high TGF-beta signaling that's driving disease. If it's high signaling, as we would propose, then the black 6 background with a relative TGF-beta deficiency state should be protective. And that's exactly what we observed. As we introduced our Marfan mutation into an ultra-pure black 6 background, greater than 20 crosses, we saw that the aneurysms were essentially disappearing before our eyes. Whereas when we put the mutation on a pure high signaling 129 background, we saw a great accentuation of the aneurysm size and also acceleration of death due to aortic dissection. And we could show this wasn't due to any difference in blood pressure or heart rate between the groups. Now, when we looked at signaling events in these different backgrounds, the results weren't subtle. We found that on the ultra-pure black 6 background, the abnormal activation of SMAD and ERK that we had seen in Marfan mice was gradually disappearing, whereas when we put the mutation onto the high signaling 129 background, you can see that all of these signaling events are greatly exaggerated. And we did a cross between black 6 and 129 in an attempt to define modifier loci, and found that virtually all of the protection on the black 6 background could be attributed to two loci on mouse chromosome 5 and mouse chromosome 11, both with very significant LOD scores based upon the number of markers that had been utilized. We found that when you consider both of these loci in combination, there's clear evidence for epistasis, with the LOD score jumping up to about 12.8. So we're still working our way through these loci. There are a number of genes of interest with a theme of integration of calcium, TGF-beta, and MAP kinase signaling. We're particularly intrigued by the MMP17 gene on mouse chromosome 5, a known regulator of ERK activation, loss of function mutations previously implicated in thoracic aortic aneurysm, and a variant that looks quite substantial that differentiates black 6 from 129 with loss of the normal termination codon. On mouse chromosome 11, we find the MAP2K6 gene, again, a mitogen-activated protein kinase that is activated by MAP3K4, the human modifier. So it appears that through the analysis of two different species, we may be identifying a pathway of modification. And again, a very deleterious mutation that discriminates between black 6 and 129. So again, this all seemed to make sense, hitting down again at the level of ERK activation. So we think taken together, these data suggest that natural genetic variation that attenuates TGF-beta or ERK activation in both people and mice with Marfan syndrome has the ability to protect from vascular disease. And we believe strongly that pharmacologic agents that leverage nature's strategies represent novel and potentially potent therapeutic options. And in fact, we're partnering with a number of drug companies to explore the possibility of drug development for some of these therapeutic targets. And we still would love to reconcile the so-called inconvenient truths regarding the low signaling, high signaling paradox in Loeys-Dietz syndrome. We really think this is important for there to be consensus about moving forward with some of these strategies. So in thinking about this, we believe that we may have gained insight from the so-called TGF-beta cancer paradox. So a very well-defined paradigm in many solid tumors is that early on in the progression of the tumor, when the cancer cells retain TGF-beta responsiveness, TGF-beta acts as a tumor suppressor. But at some later stage in pathogenesis, when there's a somatic loss, for example, of the second TGF-beta receptor allele, there's complete collapse of signaling potential within the tumor that then secretes lots of TGF-beta into its environment in an attempt to compensate. And in that manner, overdrive signaling by neighboring signaling competent stromal cells that have not lost their second allele, for example. So we wondered whether this paracrine overdrive model might be informative for inherited vasculopathies. And one observation that was absolutely clear from the get-go was that the distribution of aneurysms in these conditions is distinctly non-random. They frequently, almost universally, occur at the base of the aorta, the so-called aortic root, very often at the base of the subclavian arteries, in the proximal descending thoracic aorta, in the suprarenal abdominal aorta. So what we wondered is that at these points, is there importance of the fact that there is interface between vascular smooth muscle cells of different embryonic origin? It really was uncanny the way that these interfaces predicted the location of aneurysm. For example, we're going to focus on the second heart field lineage of vascular smooth muscle cells that directly interface with cardiac neural crest-derived vascular smooth muscle cells right at the base of the aorta. And what we wondered is it possible that one lineage, let's say second heart field cells, show physiologically low TGF-beta signaling and are more vulnerable to the effects of a heterozygous loss-of-function mutation than their nearest neighbor, cardiac neural crest-derived vascular smooth muscle cells. We thought if this were true, then there would be collapse of signaling in the vulnerable second heart field cells. They would secrete lots of TGF-beta into their environment, and in that manner overdrive TGF-beta signaling by the neighboring cardiac neural crest-derived cells. So Elena Gallo really took this on, a truly valiant effort, and I think that she's now achieved clarity. What she did using lineage tracing is she was able to purify pure second heart field derived and cardiac neural crest derived vascular smooth muscle cells from control mice. In this experiment, she's using flow analysis to monitor for phosphorylation of SMAD2 and 3 in response to treatment with TGF-beta. And what you can see is in control cells, both lineages show a nice, robust response to TGF-beta with increased phospho-SMAD2 and 3. If we look at the cardiac neural crest-derived cells from Loeys-Dietz syndrome mice, you can see that there's still this very robust response. They essentially couldn't care less that they have a heterozygous loss-of-function mutation. But the same is not true for Loeys-Dietz syndrome second heart field-derived vascular smooth muscle cells that show a profound perturbation of their ability to respond. We could look at this by multiple different methods. Here I'm showing you by Western blot analysis that in control cells, both the second heart field and cardiac neural crest lineages show a robust response to TGF-beta, but in Loeys-Dietz syndrome, there's a selective impairment of this response in second heart field-derived vascular smooth muscle cells. And here I'm showing you the results for many, many different cell lines. Again, a collapse of signaling that's specific to Loeys-Dietz syndrome second heart field-derived cells. So then we began to explore what's the consequence of this? What happens in these second heart field-derived cells when there is collapse of signaling? We already had a reasonable hypothesis that the angiotensin II type 1 receptor was involved because losartan is such an effective treatment. When we looked at expression of the AT1 receptor, we found that this is uniquely elevated in the second heart field-derived vascular smooth muscle cells from Loeys-Dietz mice, not in second heart field-derived cells from control animals. So we see an epigenetic release of expression of the angiotensin II type 1 receptor. Then we asked, well, what's the consequence of that? And found that when we treat Loeys-Dietz-derived second heart field cells with angiotensin II that are expressing high levels of the receptor, we see profound ERK activation. The same is not true in the second heart field cells derived from control animals or in the cardiac neural crest-derived cells from Loeys-Dietz syndrome. So what is high P-ERK doing in these cells? Well, the answer is that it's driving lots of production of TGF-beta, of the ligand itself. So again, the sense that there's an attempt at compensation going on in these cells that can no longer respond. We could block the TGF-beta expression in response to angiotensin II, as you might imagine with angiotensin receptor blockers, also with ERK inhibitors, also with PKC inhibitors. So we're marching down our therapeutic effects and finding that all may be relevant to this observation. So what's all this TGF-beta doing that's being secreted by these second heart field cells? Well, we then looked at where we're seeing the high p-SMAD2 signal in the aorta. In control animals, you can see the cardiac neural crest-derived cells labeled in green. There's really not any high TGF-beta signaling that coincides with that signal. But in Loeys-Dietz syndrome mice, it's exactly where you see the cardiac neural crest-derived cells as to where you see the high TGF-beta signaling. Again, beautiful correlation in mouse after mouse. So the final conclusion is that in second heart field cells, there's collapse of TGF-beta signaling, high AT1 expression, high ERK activation, high production of TGF-beta, that then via paracrine overdrive, drive signaling in cardiac neural crest-derived vascular smooth muscle cells with the hypothesis that this is driving aneurysm formation. So we still have to test that hypothesis. And what we reasoned is if all this is true, then selective potent TGF-beta antagonism by knocking out the SMAD2 gene in the second heart field cells should not make that big a difference because they're already really impaired for TGF-beta signaling. But if we selectively abrogated TGF-beta signaling by knocking out the SMAD2 gene in the cardiac neural crest, this should be protective if that's the pathogenic event that's critical. So Elena did just this when she knocked out the SMAD2 gene specifically in the second heart field of Loeys-Dietz syndrome mice. As predicted, we saw no difference. There's still aneurysms. They're just as big as they ever were. If we did this in the cardiac neural crest, we saw that there is complete prevention of aneurysms in the Loeys-Dietz syndrome mice. So indeed, the paracrine overdrive of the cardiac neural crest cells appears to be the culprit. If we look at aortic wall architecture, it's really abnormal in Loeys-Dietz mice with high collagen production shown in blue. In Loeys-Dietz mice, where you knock out the SMAD2 gene, there's full preservation of normal aortic wall architecture in association with abrogation of TGF-beta signaling. So now we've proven this entire pathogenic scheme. This nicely predicts that angiotensin receptor blockers or ERK inhibitors will be protective. It also predicts that there might be context-specific consequences of relative TGF-beta antagonism. If you're having selective effects on the vulnerable second heart field, this might make things worse. If you're having pronounced effects on the cardiac neural crest, this is predicted to make things better. But perhaps most importantly, this model will inform the design of future clinical trials. Instead of asking, what does this FDA-approved dose of ARBs do for these conditions, we can ask what dose of angiotensin receptor blockers is needed to inhibit AT1-mediated expression of TGF-beta1 in second heart field-derived vascular smooth muscle cells. So it gives us an intellectual context within which to frame the parameters of a trial. So as recently as 10 years ago, we had this weak tissues hypothesis that was highly pessimistic. We think that the prospects for disease treatment are now substantial, with many different therapeutic targets that are being pursued. Perhaps of equal importance, we've learned about things that perhaps are best avoided in Marfan syndrome. I'd like to end by acknowledging the truly remarkable people that I have the privilege of working with every day. They truly are exceptional. The ones who made major contributions to the work that I showed you are shown in red. I'd like to also acknowledge my fantastic collaborators at Johns Hopkins and also other institutions, prominently including Bart Loeys and Francesco Ramirez. I'd also like to acknowledge my funding sources, and I thank you for your attention. I'd be happy to answer questions.
Did you sequence the MAP3K4 families to try to identify a causal mutation for that protective effect?
Yes, so what I can say at this point is that it's not in coding sequence. So we're struggling with that. Many possibilities, but a lot of obstacles to reaching clarity on that question. Go ahead.
Thanks very much. Absolutely beautiful talk. Thank you. My question is the SMAD2 selection that you chose to knock out in the secondary heart field. You've got SMAD2 and SMAD3 downstream of the TGF-beta receptor, and most of the canonical signaling is thought to be SMAD3 related. I know it's the phospho-SMAD2 immunohistochemistry is easier and you get a nice increased signal, but what's really happening with the SMAD3, and is that less important?
Yeah, so we did use antibodies that were specific for SMAD2 or antibodies that react equally well with SMAD2 or SMAD3. And we found that the suppression of signaling effect of knocking out SMAD2 in the cardiac neural crest was essentially complete. So it's suggesting that SMAD3 is not playing a major role, at least in that specific anatomic position.
Just going back to your original, the original theory about Marfan's, is there any structural element to fibrillin at all, or was that just completely wrong?
Yes, so it actually was a homology between fibrillin-1, fibrillin-2, and the latent TGF-beta binding proteins, or LTBPs. In the center region of both fibrillins, there is a region that has many consecutive EGF-like domains interspersed with a so-called 8-cysteine domain. And it turned out that that central organization of fibrillins looked remarkably similar to the structure of LTBPs. So we reasoned that TGF-beta binds to LTBPs, fibrillins bind to each other. Perhaps that would infer that there is a physical interaction, which was later demonstrated.
But is there a structural component? Is there a loss of fibrillin integrity
that's driving disease?
Not driving disease, because it's quite clear after that beautiful talk what's driving disease, but I'm just wondering if there's a adjunct structural of loss of fibrillin structure.
So virtually Well, most of the manifestations of Marfan syndrome are recapitulated in people and mice that have primary mutations in TGF-beta effector units, with the exception of eye lens dislocation. And the eye lenses are normally held in place by structures called ciliary zonules, which are simply bundles of microfibrils. So we think that that is a relatively pure manifestation of a structural deficiency of fibrillins.
One last question.
Yeah, thanks. That was beautiful. But it's also depressing and disconcerting. If this is true for therapy of most genetic diseases, and we all have to spend 10 years agonizing, and our brains are not as good as yours, where is this leading us? So that is one thing that's in my head. I've become utterly depressed about the prospects for therapy. So do you think you've been that Marfan is a particularly difficult example of getting to treatment from a genetic problem, or do you think this is probably the realistic view of it, and this is where we all need to go?
If we think about disease genes that were identified around the time that the Marfan gene was found, so CFTR for CF, for example, or dystrophin for DMD, their stories are still playing out. So my bet is that this is representative of what we have to slog through to really understand mechanism and to really make a difference in disease treatment.
Thank you.
Anne was depressed, but I was very inspired. So we'd like to thank you
Sure,
very much indeed.
Thank you
a
so
wonderful
much.
talk.